Good evening, everyone. My name is Pamela Munster. I'm the director of the Hereditary Cancer Clinic, and it's my pleasure to open this webinar with a focus on breast cancer, what's new, what mutations are new here. I'm joined by a very illustrious panel who I'm going to ask to introduce themselves in just a minute. More importantly, however, I like to bring back a little bit what we do. What we're doing is we had this clinic created because we felt it was really important for people who are diagnosed with a mutation to have a comprehensive care that consists of multiple folks with expertise, such as oncologists, surgeons, geneticists, genetic counselors, and other experts who can help us guide us through care when someone has a mutation. So with this, I'm not quite sure why I'm on my head, but if you see me on my head, then that's not. I'm going to try to fix this. But I'd like to have you. Introduce yourself in just a second. While I'm fixing myself being on my head, Marta, why don't you start? That's okay.
Yeah, of course. My name is Marta Sabadini, and I am one of the genetic counselor that works in the Hereditary Cancer Clinic with Dr. Munster, and I see patients with mutations in genes that predispose or increase the risk for breast cancer, as well as their family members, and we discuss testing and the implications of testing both before and after the results.
Thank you, Marta, and very great to have you here. Julie Mack.
Hi, good evening. My name is Julie Mack. I'm also a genetic counselor in our clinic. I'm really excited to have been doing this with Dr. Munster now for, I think, almost like 8 years or something like that. It's been a fantastic, I think, addition to what we have to offer, and looking forward to the conversation tonight.
Thank you, Julie. So great to have you. Beth Lynn.
Thank you. My name's Beth. I'm a nurse practitioner in the Hereditary Cancer Clinic. So once Marta and Julie have seen a patient and talked to them about their risks, they then transfer over to me, and it's my job to keep them up to date on all their screening, to do their referrals when they need to see a specialist, and so on. It's very glad to have you be here again tonight.
Thanks, Beth. And Dr. Melisko.
Hi, I'm Michelle Melisko, and I'm a breast medical oncologist that takes care of patients both with hereditary breast cancer as well as a huge population of patients without hereditary breast cancer. And I'm excited to be here. This is my first time joining this panel, and I'm excited about talking about new things on the horizon in terms of what we should be advising our patients for family members who in families that have a hereditary mutation, as well as talking about how we are modifying our treatments for patients, both in terms of breast cancer screening, treatment, and then screening for other cancers once they've been diagnosed with or discovered to have a hereditary cancer gene.
Thank you so much for doing this. And as I promised you, there's nothing that's going to be a surprise for you. And I think we'll be looking at this as a conversation. So what I like to get accomplished today is that anyone who has a mutation and it's either been in our clinic or is referred to our clinic gets a little bit of an idea. What's going to happen then is what are we looking for, how we can prevent breast and other cancers, and how anyone with a mutation can also very significantly impact their family members by encouraging them to get tested or encouraging them to get screened. When Julie and I first talked, is like when it was not common that everyone had access to testing, and only BRCA1 and BRCA2 would be routinely be tested. It was a lot clear what needs to be done, but now we have multiple mutations that pose a risk for breast cancer. We have multiple ways of doing screening and doing risk reducing preventions. But I think what's also really important is these guidelines constantly change. And I think part of the webinars is also like, what are the changes in guidelines? And even those on the call who may have gotten guidelines, they may have changed over the years. And I think part of our task is really to go through this. If I may, bring up the genes, and either Marta or Julie talk about who are the major genes that convey breast cancer, and then just to remind everyone of this. For all the participants, if you find that we don't discuss your gene, please put this in the chat. We will have an opportunity at the end for about 45 minutes for folks to have questions. Julia, Marta, anyone wants to briefly go through these genes? And we go into more details of every one of them, and I have a case prepared for pretty much every gene.
Yeah, sure. I'm happy to give a quick overview. As you were saying, Dr. Munster, we started off 20 years ago, 15 years ago, when we saw families that we suspected had some type of genetic risk factor for breast cancer, really thinking mostly about the top two on the list there, BRCA1 and BRCA2, or BRCA1 and BRCA2. And over time, we've learned about many other genes that can cause families to have a higher risk of breast cancer. And of course, we're not here just to talk about the risk, but all the things we can do with that information and how to use that information. I pulled this table from the most recent guidelines that we follow. So as Dr. Munster said, your family may have a different gene, but these are actually the genes that are sort of most confirmed to have a risk of breast cancer associated with them. And I did list them in approximately from highest risk to lowest risk. And so those are listed here. I drew a line across between PALB2 and CHEK2 because we'll be talking more about this later, but basically the genes above the line, we think the risk is high enough that we always talk about breast MRI screening. And below that line, we tend to individualize things a lot more, but we'll get into that in the cases. So these are the genes, as I said, that are most clearly proven to have a risk of breast cancer, particularly in people who are assigned female at birth, although some also have risk for men. And I do want to emphasize here that even at the higher end of this list, not everybody gets breast cancer, and also that these are lifetime risks. So they're measured usually till someone lives to be 80 years old. So I don't, I understand we take these numbers very seriously, but I don't want someone to look at this and think, oh, something's going to happen tomorrow. This is sort of the information we use to plan ahead and be on top of things.
Thank you very much. If you can take the slide down, we can go on panelist view. So let me introduce the first case, and this is a very common case we often see. What I want you to not think this could happen to you, but also would want to think, if you're in a similar age with a similar diagnosis, what would happen to you if you presented with breast cancer? Our first case is a 51-year-old woman, perimenopausal, who has a known BRCA1 mutation. She finds a new lump in the breast, and she also has a lump in the axilla, the armpit. She comes to see Dr. Melisko. Dr. Melisko, what would you do next?
So if this is, a woman who's 51 years old, and you say that she already, knows that she has a BRCA mutation, presumably that's because she had a family history or some along the way decided to get tested, then, the curious thing is, we don't know exactly what the screening that she was going through and how quickly this mass developed. But the first step, of course, would be to do a biopsy. And the probably appropriate would be a core biopsy. There back in the day, years and years and years ago, they might do an excisional biopsy, but it would be a core biopsy of the breast and probably a fine needle aspiration biopsy of the axillary node to determine if that node contained cancer. And, presuming going forward with the case, if this did contain cancer, We would want to know the mutation status, so the estrogen receptor, progesterone receptor, and HER2/neu status. And typically that's performed on the core biopsy, not necessarily repeated on the axillary node. Typically the nodes are going to have the same biology. And if this is a BRCA1 patient, then, there's an overwhelming chance that this is going to be a triple negative breast cancer, although not 100%. I think one thing that's very interesting that's evolved over my career of, now to almost 25 years is that, we used to think that every BRCA1 mutation carrier had a 100% chance of it being a triple negative breast cancer, but I have seen ER positive breast cancers rarely. And then BRCA2 is, more evenly split, that we do see ER positive BRCA2 and we see HER2 positive cases. So we need to know about the biology in order to make the best treatment option recommendation. Even though we know that, most patients with a BRCA mutation who are diagnosed with breast cancer are eventually most likely going to be recommended to have a mastectomy, depending on the biology, we still may recommend patients to get neoadjuvant chemotherapy or some form of neoadjuvant treatment to assess the response.
Well, Dr. Melisko, can I ask a question here? So this patient finds alarm, right? You would urgently get some form of biopsy, and FNA, fine needle aspiration, or biopsy to make a diagnosis. But then in this case, with someone who has a lump in the axilla, would you do surgery first, or would you do chemo first?
So as I was saying that, if we biopsy the axillary node and it's positive, then certainly for someone who has a triple negative breast cancer or a HER2 positive breast cancer, it's almost certain that those patients are going to be a candidate to receive chemotherapy or some form of biological therapy. So we would like to give that before going to surgery. There are rare cases with a triple negative breast cancer where we would take someone to surgery first, but there is a clear advantage of giving some amount of chemotherapy before surgery, because then we can risk stratify the patient. Meaning that if we give chemotherapy, and let's just pretend that this is a triple negative breast cancer that has a positive lymph node, then the current standard for that would be to get chemotherapy plus immunotherapy. And we know from, many different trials that if a patient, no matter how big their cancer is when it starts, if we can shrink it down, and in fact, in some cases, make it go away, something that we call a pathologic complete response, then that patient has a much better outcome. And so I often tell patients when they're first come to see me, they'll ask, what is my stage? And this is, something that I think is very important, a message that I like to send, in a hereditary cancer context or not, that, stage may not be as important as we once thought. And certainly stage at diagnosis, it's really what happens at the time of surgery. So if this is a triple negative patient, we would want to give them chemotherapy first and in combination with immunotherapy, pembrolizumab.
Okay. And then how long about is this treatment?
So typically for, outside the context of a clinical trial, the regimen that we follow is something called the Keynote 522 study. And that was a trial for patients with triple negative breast cancers, led to the FDA approval of pembrolizumab. And patients would receive this treatment for about 6 months. So they would get about 6 months of combination chemotherapy plus the immunotherapy pembrolizumab, and then would go to surgery. There are experimental approaches, experimental trials looking at different combinations of chemotherapy where maybe they could cut that treatment short. But the standard in my mind is still to give this full court press of chemotherapy, because we have a tremendous opportunity to cure someone by giving the treatment first and assessing the response. And, I think that's an important message, is that we do cure people with triple negative disease of cancer, despite the fear on the street of it being so deadly and so awful. I mean, there's a good percentage of patients that we can cure with our treatments.
And then are there women with triple negative breast cancer of a small enough tumor where you don't think you would need to give chemo?
Yeah, that's a really good question. And so in that clinical trial that I mentioned that led to the FDA approval of immunotherapy, they enrolled, anybody that had cancer that had spread to a lymph node, or anyone who had a tumor over 2 centimeters. And I mean, this is a kind of a loaded question because, you can almost always make a tumor measure over 2 centimeters if you follow up. So this particular patient, we're presuming, she ends up getting breast imaging and gets an MRI. And that's, a whole other can of worms about what kind of breast imaging that someone might get a mammogram where the mass measures, 1.7 centimeters, and then they get an MRI and the MRI makes it measure 2.1 centimeters. So in my practice, in my mind, I certainly consider neoadjuvant chemotherapy, really for any triple negative patient that has a tumor over about a centimeter. But, by the rule book, the patients in this trial, they had to have tumors, about over 2 centimeters to get immunotherapy. There may be some patients that have tumors that are triple negative that are, 1 centimeter that could get by straight by going to surgery and then doing a shorter course of chemotherapy. And that's where I, turn the question back at you is, this is a controversial area where some people think, we should throw the book at everybody and give everyone immunotherapy, try to bring that limit of where we would give chemotherapy to everybody, give immunotherapy to everybody with a triple negative disease, but we may be overtreating some people. So that patients with tumors between 1 and 2 centimeters, I think, are that tricky point. And someone who has a tumor less than 1 centimeter, I'd probably take them to surgery first.
So I think what I'm trying to have you hear is that patients with triple negative breast cancers are really curable. And it's really important to be diagnosed at an early stage, as often when patients have BRCA mutations, they may still end up with breast cancer, but we feel very strongly that patients who get routine screening have a much higher chance to be found at an earlier stage and at the stage where they may not need as much chemotherapy or not as long chemotherapy. What about the PARP inhibitor? So now this patient has 6 months of chemotherapy, then surgery, and we talk about surgical options just a bit, but then another 6 months of immunotherapy. What about the PARP inhibitor?
Yeah, so there's data, that looks at for patients that have either a BRCA1 or a BRCA2 mutation. And, we didn't talk much about what if this was a BRCA2 patient and they had ER positive disease, but, assuming, again, sticking with the story of a BRCA1 mutation, if they went through the chemotherapy and they received immunotherapy preoperatively, and then at the time of surgery, if there is no cancer left, then, they can basically finish up their treatment by going forward and completing, a number of months of immunotherapy, 9 more doses of immunotherapy, the pembrolizumab. But if they don't achieve a pathologic complete response, meaning that there's still cancer found in the breast, this is not found in the body, but in the breast, somewhere else in their when they go to surgery, then they would be a candidate to receive a PARP inhibitor. And so that's based on a clinical trial in which patients who had residual disease after treatment, after chemotherapy, were randomized to get, a PARP inhibitor, olaparib, or a placebo, and it showed, dramatic improvements in reduction in risk of recurrence. And so, yes, patients would go on to receive a year of immunotherapy, a year of a PARP inhibitor, and we would, in these days, continue on the immunotherapy to finish up that as well.
So fairly a long therapy. So I think, again, really pointing to the fact screening is important. Now, she has a 20-year-old daughter, and at one of the visits, the daughter comes along, and Dr. Maliska refers her to a genetic counselor, like Julie or Martha. She's 21. What would you recommend to this young woman? Julie, why don't you start, and maybe we hear from both Martha and you.
So I think when I talk to someone who is in that age range, there's a few things I think about. I think especially when they know that their mom is positive, I want them to feel really comfortable asking their questions, talking to the genetic counselor, or talking to the mom's doctors as appropriate. I think it's a good time to be thinking about it. I want to emphasize that at 21, their risk of breast cancer, even if they test positive. And just to remind everybody, if your mom is positive, you have a 50-50 chance of also having that same genetic risk, that their risk is very, very low at 21. We can never say 0, but it's very, very, very low. And we don't typically start doing breast MRIs and regular checkups with people like Beth until age 25. So I don't want them to feel pressured, but I want them to feel open to asking questions. And if they do come in, which I think a lot of people do at this scenario, and say, well, I just want the information. I want to know, like, I'm watching my mom go through this. I just want to figure this out. Again, it's their choice, and we honor that. But I might mention, I think it's when you're seeing the cancer happening right in front of you, it's really hard to get the positive result and feel that that's separate from getting a cancer diagnosis. And so if I might bring that up as something to think about, if somebody really, really still wanted to do it, again, it is their choice. I would spend a lot of time just emphasizing this doesn't mean that the same thing's going to happen to you. And it definitely doesn't mean the same thing's going to happen to you right now. So those are the kinds of things that are coming into my mind for her daughter.
Julie, what I'm hearing is like, Julie, what I'm hearing is this 22-year-old really does, this 21-year-old does really not need to be tested right now. She's not ready for it. There's nothing really going to change in terms of screening in a 21-year-old. Is that fair to say?
I think that nothing would change in screening, and they don't need to do anything. But I think that the part I would just add is I understand why this feels like an urgent question to this person, and I would be open to having a conversation. I'd probably try to encourage them to wait, but it is like, it's their right as a 21-year-old if that's what they decide to do. But I would probably try to put up all of the just things to think about is what I tend to say is, I don't want to tell you what to do. It's not my job, but I want to make sure you've thought about all of these things.
So Marta, because this daughter is really worried about having breast cancer, of course, and she doesn't really dare to ask Dr. Meliska what her risk is. What would you tell her when she asks her, like, am I going to get breast cancer?
Right. Going back to sort of like, of course, I agree with everything Julie said. And I think one of the things I never get tired of stressing is that I actually think it's a very appropriate referral for someone to see us at that point. And not that much, again, for testing, which we would discuss and honor their desire if that's what they wanted, but really to give them a place to ask this question and make sure that there's also no misunderstanding or conclusions that are inappropriate. So we usually explain again what the risk is of having this mutation and what it would mean for their health long term. So I think that's a very good time to have that conversation about this is what it is, and let's make a plan for the future in terms of when is a good time to test, when is a good time to start screening, when is a good time to set up the care that you need, and how can we support in all of that. So in talking about the breast cancer, we, as Julie was saying, we say that having a mutation is not a guarantee someone will develop cancer. In fact, there's as we saw the numbers before, there's for each gene, even if it's for the highest, there's about a 30% chance, or 3 out of 10 women will never develop cancer. And often this is the case that we can highlight in a family and show how some people did mutation have and don't have cancer. But we do talk about how with BRCA1, definitely the risk is high. And how do we want to set up and prepare for screening and for doing everything we can in case cancer does happen and develop, and how we want to support them and take care of them.
Thank you, both of you. So this patient actually wanted to get tested and found out she's also BRCA1 positive. We made a referral to our hereditary cancer clinic, and she is seeing Beth, our wonderful nurse practitioner. And the first question this patient, of course, has for Beth is like, I need birth control, but I hear birth control is bad for you, is bad for breast cancer. Beth, not putting you on the spot, but this is a very common question we address often in our clinic, and it's an important question. And
Yes, it does come up all of the time. The first thing I would ask is, why do they want to go on birth control? If the reason the woman wants to go on birth control is to prevent pregnancy, then I would say, then by all means go on birth control. I would I'm a women's health MP, so I would also talk to them about other forms of birth control that might be a little more reliable for somebody their age and perhaps be better for them. But if they want to go on birth control, absolutely. The question I get a lot is this going to increase my risk of breast cancer? And I tell them the data is a little mixed.
And the best, can we be more specific? Are we talking oral birth control? Are we talking IUDs?
Sure. Most of the time for younger women, they're talking about birth control pills, but for a combined oral contraception, so this is your standard birth control pill that has both estrogen and progestin. We believe that it will increase the risk of breast cancer a little bit. We don't know exactly how much. But so we wouldn't, in terms of somebody whose lifetime risk is higher than 60%, their increased risk is probably not so high that they shouldn't go on birth control pills. I mean, it might increase the risk from 60 to 61 or 62, but it's not going to increase their risk dramatically. There's been at least one study that looked at least in the short term, for really young women going on birth control pills, that might increase their risk for a temporary period of time. IUDs are probably better. A Mirena IUD, a hormonal IUD, is probably a little better because the amount of hormones that get circulated in the bloodstream are lower. So the amount of hormones that are actually getting to a woman's breasts are lower. Certainly a non-hormonal IUD like a Paragard is going to not, because there's no hormones in it, that's not going to affect the breast tissue at all. But really the starting point of that conversation is, why do you want to go on birth control to begin with? And if someone's trying to prevent pregnancy, that's far more important for a 21-year-old, for them to go on birth control or something that's effective for them than worrying about their breast cancer.
So that's like and just reiterating this a little bit, what Beth is saying, if you have a BRCA1 mutation, your risk of breast cancer is so high from the BRCA1 mutation. The excessive risk from the birth control contributes very little to the risk. And I think the birth control has to have a purpose. We wouldn't recommend for someone to go on birth control for acne. That's probably not a good enough reason in someone with a BRCA mutation, or at least not in a hormonal oral pills. But for pregnancy prevention, this is totally safe. I think we also should mention that birth control use has reduced the risk for ovarian cancer, which in someone with a BRCA1 mutation is a really important part. So as someone with a BRCA mutation comes to our clinic at 21, these are the discussions we have. We have a very detailed discussion: is what is the birth control for? What is the risk benefit? Is like, and then, this risk may change when someone is 30. This risk may be changing when someone is 30. So this is an ongoing conversation. Again, a reason why we have this very specific clinic for patients with very, very specific questions. Now, she has another daughter who is 20. She gets tested because she wanted to know, since her sister is positive. She is negative for the BRCA mutation. Julie or Martha, can you speak a little bit to what a true negative is? What the risk for breast cancer is?
Yeah, sure. So what we define as a true negative is someone in a family where there's a known genetic risk factor, inherited risk factor that increases the risk for cancer. And that explains the cancer events in the family. When someone does not inherit that mutation, we call that a true negative, meaning that person does not have the risk that come with that gene. And probably it's kind of like saying that the fact that their mother had this cancer diagnosis doesn't really get factored in when we think about the recommendation for their cancer screening. So in a case like this, where there's an obvious, there's a BRCA1 and we have like a triple negative breast cancer, this is not something that we would really think about when we make the recommendation for her screening. And depending on the rest of the family history, we would probably tell her that she can follow general population screening, so starting screening around age 40 or so. The one note I want to make in this is that, as we saw at the beginning, the table comes with different risks. And so it's easier, sort of like when we have a family with a BRCA 1 or 2 mutation, and we can clearly sort of attribute or track the cancers associated with the breast cancer. We say, you know, this, you have not inherited the risk factor, so we can have you follow general population guidelines. Some of the genes that come with a lower risk, we might still be a little bit more unsure about how many of the cancers in the family or what was the contribution of the genetic inherited risk. And so we might have a little bit of a more nuanced conversation about the recommendation. But generally speaking, a true negative is someone to whom we can tell, we know what caused the cancer, you don't have it, so we don't have to really think about an increase, or we don't have to consider you at an increased risk.
Thank you. Back to Dr. Melisko. A 45-year-old premenopausal patient with a PALB2 mutation presents with a new stage 2 breast cancer. Her breast cancer is estrogen receptor positive, and she has completed all her chemotherapy. What's next since she's ER positive? What does hormonal therapy entail in this patient?
Yeah, so these kind of cases are tough. I'm glad you already bypassed the discussion about whether she should get neoadjuvant treatment or get treatment first, and what is the role of lumpectomy versus mastectomy, because these are such complicated discussions. We could probably spend an hour just on that case. But if we're focusing on an ER positive patient that's stage 2, we now have data from, 2 clinical trials looking at the value of cyclin-dependent kinase inhibitors, but the backbone of hormone therapy for a patient like this is going to be, somewhere between 5 and 10 years of adjuvant endocrine therapy. And, I tend to lean towards longer, adjuvant endocrine therapy, rather than shorter. And, the first decision for someone who's a BRCA2 mutation might be at what age and what year would they be, getting, undergoing their oophorectomy to reducing oophorectomy. Will they actually do that? For most patients with stage 2 disease, we are going to be recommending at least that they try ovarian suppression in combination with an aromatase inhibitor, based on the data from the SOFT trial, where patients, they were randomized to tamoxifen or ovarian suppression plus tamoxifen or ovarian suppression plus AI. And we found that ovarian suppression plus AI was superior. Of course, that has a pretty big impact on quality of life. And so for younger women, even though we know the data is very strong that giving a very aggressive hormone therapy approach is important, sometimes, quality of life is unbearable. So a patient like this, I would have a discussion about, which upfront hormone therapy are we going to recommend? As I said, it could be tamoxifen, ovarian suppression, but a stage 2 patient who, if they want to be very aggressive, they'd start out with ovarian suppression plus an aromatase inhibitor. And then we will, then we would talk about duration. And part of that depends on how well they're tolerating it. The goal, I usually set people up to say, there's no question, we want to get you through 5, we are shooting for 10. There's data in the postmenopausal population that, 10 years of AI is better than 5 years of AI, but there's a study that says that 7 is good as 10. So we're always kind of struggling, for someone who's really having a hard time with hormone therapy, do they really need to push it out to 10, or could they get by with 7? But I think that, these are discussions that have to be individualized. And then, in terms of which of the hormone therapies is the best. And then on top of that, now we have the 2 CDK4/6 inhibitors, ribociclib and abemaciclib, and they have different side effect profiles. They have one is, FDA approved to be taken for 2 years. One is to FDA approved to taken for 3 years. So we have a conversation about that. And I think, probably beyond the scope of this discussion, what the side effects are of each of those. But, it is getting more and more complex, kind of the mix and match of options for women with ER positive disease. But it's a long course. It's a long time of treatment.
Yeah, and I think this is what I'm trying to really drive home is like, it is very true that we can cure most breast cancers, but it is a long and arduous way. It's like, I mean, breast cancer is highly curable, but God, if the only purpose of my academic career is to spare women from having breast cancer by getting them screened and prevented early, I would feel very, very happy. I think if we can, right, Michelle, is like, if you can spare someone 10 years of misery, we would do a lot for that.
Yeah, absolutely.
So this person also has a sister, and she got tested. And she's seeing Beth with a PALB2 mutation. So Beth, what needs the sister do? PALB2 mutation is not quite as well known as BRCA1 or 2. Can you talk a little bit about your impressions about PALB2 and what you would recommend her sister, who is 42? What is her sister going to need to do?
So what we would talk about first is risk reduction versus screening and the difference between the two and the pros and cons. Generally, when I meet patients who have a close relative like a sister, particularly if it's somebody who's younger than they are obviously very anxious about their particular risk. And we have to consider family history when we talk to people about how to do screening and how to manage the risk. So I would talk to her about screening and how effective it is and the chance, that we've actually done a study on this, and doing high risk screening is pretty darn good at finding cancer early. But if somebody gets a hormone positive cancer, that still doesn't, even if it's an early cancer, it doesn't mean they aren't going to be going through treatment for a considerable period of time. And so I'd make sure that they knew that screening is not prevention, screening is detection. And our goal is to detect as early as we possibly can so that Dr. Malisko doesn't have to treat a bigger cancer. Then we talk about risk reduction and the options of that and the pros and cons. And depending upon what her sister has done as far as surgery, she may have positive impressions of that and she may not. And so addressing her concerns. But PALB2 has a significant risk of cancer, but I think we'd really be talking about her sister, what has happened with her sister, and how do we use that information to look at her risk?
Okay. Dr. Malisko, if someone has an estrogen receptor positive tumor, can they get pregnant during the hormonal therapy?
Yeah. So, I mean, gratefully, we have had some very, very brave women who have participated in a clinical trial called the Positive Study that was led by a group at Dana-Farber, and other institutions across the country participated and enrolled patients. And they looked at women with ER positive breast cancers and gave them the opportunity to discontinue their endocrine therapy after a minimum of taking it for 2 years. And this was not a randomized trial. You can't randomize people to get pregnant or not get pregnant, but it was an observational study where they looked at women who had ER positive breast cancer, and they took, they then followed them and saw how many of them were able to get pregnant. And what was wonderful was that a high percentage of these women who discontinued their endocrine therapy prematurely to try to get pregnant were able to get pregnant. And they followed these women for a number of years and compared the risk of recurrence in these patients to a historical control. Again, looking back at that trial I mentioned, the SOFT trial, we have now, over 10 years of follow-up And the rate of recurrence of these patients who discontinued their endocrine therapy temporarily to try to get pregnant was very similar, acceptably close to what we call the historical controls. So in this study, and I don't remember the exact percentage of, the number of women that got pregnant, but was in the, well over 50%, 75% of women were able to get pregnant. Some of them using harvested eggs, some of them got pregnant naturally, and then the majority of them did go back on their endocrine therapy. And that's the key, is that, counseling patients of mine who, are, motivated, they wanted to get pregnant. It's an unfortunate thing that happens. We see this a lot in the Bay Area. Women are in their prime of their life, their careers, they're in their late 30s or even early 40s, and they are just thinking, when am I going to make this happen? And then they're diagnosed with breast cancer. And so we do harvest a lot of, have a lot of patients see the endocrinologist, harvest eggs beforehand. So it's very feasible for women to, use their eggs and get pregnant and then start the hormone therapy. I think we run into trouble. For me, I struggle a little bit when a patient goes off their endocrine therapy and then we want to get them back on it. And then they say, well, now I think I want to try for a second child. And, I get a little bit more nervous if they just stay off of it. In general, if patients can get back on that endocrine therapy within a couple of years, I feel pretty good about it.
Thank you for that. Talking a little bit about the maybe what we call lower risk mutations, such as ATM and check. We have a 30-year-old with an ATM mutation who had a mother who died of breast cancer at age 45. Beth, what does her screening look like, and what are we talking about risk reducing surgeries? And you can, as you often do, you can refer these patients back to me if you're not sure how to answer this.
And I do frequently, as you very well know. For a moderate risk patient, I can give them all the statistics, and Julie and Marta will have already talked to them about what their actual lifetime risk is. But when somebody has a close family relative who's had breast cancer, it certainly affects how they think about their risk. So what we would talk about is screening again, and the goal of screening of catching an early cancer. And I would talk to them about what had happened with their mother. So if their mother didn't know that she had a mutation and she had gotten breast cancer more advanced than we would hope, I would try to help them understand that because they're going to be getting high-risk screening, that would be very unlikely to happen to them. And so their course, if they got cancer, their course of care and treatment would not necessarily be their mother's experience. I'd talk to them about screening, and for people of moderate risk, certainly mammograms, annual mammograms are always recommended, but the pros and cons of MRIs we'll talk about quite a bit, because MRI is a great screening tool, but they have a lot of downside to them. Primarily, they're really good at finding things that aren't cancer. And so women who undergo MRIs get a lot of biopsies done. And even though frequently those biopsies are negative, when somebody, and I'm sure there's people on this call who have had this happen, when they have a suspicious looking finding on breast imaging, from that moment, the mind has a tendency to think about, okay, if it's suspicious, do I have cancer? And once we get the biopsy back, which can be, unfortunately, quite a few weeks later, and they find out it's completely benign, it's just like a fibroadenoma or something, that period of time they still were very worried about cancer.
Thank you. So go ahead.
Oh, and just in terms of risk reduction, for the moderate risk genes, there isn't necessarily a recommendation to do risk reduction, but that's really customized by patient. And if somebody is interested in risk reduction, I would send them to talk to a breast surgeon to talk about it. We're not going to tell anybody that they can't have risk reduction just because of the mutation they have as moderate risk.
Thank you, Beth. That's a very good point. why are we doing MRIs and mammograms? One of the reasons is like, despite the fact that mammograms may not be that great for younger women, they do something different than MRIs do. MRIs are designed to be very, very sensitive. They pick up a lot of abnormalities, sometimes resulting in the fact that they pick up abnormalities that are not breast cancer. So as Beth said, that results in biopsies that then turn out to be benign or like not cancer. Mammograms are very, very good in detecting microcalcification that happens often at a little bit older age, and that these microcalcification are signs that a cancer may have developed. So the combination of both is actually really important. In the very young patient between 25 and 30, the mammogram is probably not very helpful. So we often don't do mammograms until someone is 30 in certain risk groups. There are newer ways of doing mammograms that involve different techniques, and that is incoming. And there's a lot more research on imaging going to happen. And there's a lot more research happening on blood-based testing for breast cancer. It is not quite ready for prime time, but I'm hoping by next year or so we'll have a trial available that will add a blood test to general screenings. So I think the imaging is important. I also would like to add that if anyone is thinking about risk-reducing surgeries, maybe for BRCA1 or BRCA2, start talking to your surgeon. Go talk to a surgeon, go talk to a plastic surgeon, because it's really important to do this at your time. It is a bit of an involved process. You want to have the time. You want to be able to do this in June when you have help from your family members or when the kids are out of schools. You want to be able to not be rushed into surgery. And then the plastic surgeons may have a long wait list. You may have to wait 4 months until you see your favorite surgeon. So I think take your time for making this decision. Don't let it be rushed. Julie, you have a question?
Yeah, well, I wanted to just add to this conversation about ATM or CHEK2 or some of those genes that we call moderate risk. I think we have this, sometimes we feel like, oh, we have all these genetic tests now, whatever shows up on the test, that tells us everything. And I think Marta's touched, all of us have touched on this. If it is BRCA1 or BRCA2 or even PALB2, that may tell us most of what we need to know about that person's risk. When we find ATM or CHEK2 or some of the things sort of lower on that list, then we really want to make sure we're looking at the whole picture, as you said, the family history, their reproductive history, their breast density, all of these things, because some people, ATM on its own gives you a certain amount of risk. Some of the people we're finding who have ATM mutations may have other things that we just can't find yet, other genes, other things. And so they may be the kind of people, as we said, that we do want to be talking about MRIs and other things with. And some of the people we find ATM, and this happens all the time, is literally kind of an accident. It shows up by chance on a different type of test that wasn't the goal. There's no cancer in their family. And maybe all they have is the ATM risk. We aren't missing part of the picture. We're like, it's ATM. And so I think that sort of when I think about these genes, just the range of what your risk could be with an ATM or CHEK2 goes from like pretty, a little bit higher than the average person to possibly very high. And that's where this whole team that's on this call wants to look at that whole picture, because I think it's so easy when there's a positive on the result on the test just to talk about that. But a lot of times there's multiple things going on that we want to put together into like a bigger picture.
Mm-hmm. And while we are at this is actually a very good segue into CHEK2 mutations are also fairly common, and I think some CHEK2 mutation, like the one that runs in my family, just means I'm born probably from somewhere in northern Germany, between Germany and Poland. And I always thought that CHEK2 stands for Czech, for Czech, and not for like a checkpoint inhibitor, but there's nothing to do with the geographic area. But I think recently CHEK2 mutations have been downgraded. And Julia, Marta, would it be fair to say that people who have CHEK2 mutation probably should really get seen in our clinic so that those whose risk has been decreased, we can loosen up on the screening and imaging a little bit?
Yeah, for sure. CHEK2 has been an interesting gene for quite a long time. It's been probably the first of this like moderate, lower risk genes that has been identified. But at the beginning, we had a very specific mutation we were looking at. And that was probably the one out of all the CHEK2 mutations that the one with the highest risk. And for a long time, as we started getting mutations, we didn't really have enough information to know if there was a difference between all of them. So we kind of treated them the same. With time and with coming across more patients, more mutation, we've started realizing really that it's quite different as compared to the other genes. With most of the other genes, we say a mutation is a mutation and we treat everyone the same regardless of the specific. But with CHEK2, we've really learned that there are kind of tiers of like risk in terms of the mutation a person has. In particular, there are two very, very common mutation in the population with more prevalent in the population of European ancestry that seem to give a very minimal increase in the risk. And what I think for us has been the hardest for us and for patients is really to separate that from a significant family history of breast cancer. We see a lot of people who undergo testing because they have an extensive family history of breast cancer. And the only thing that comes out of the test result is one of these CHEK2 that now will have probably very little bearing on the history. And so that's helping patients understand what is the risk that comes from what we know in the family and what is the risk that is associated with what we see on the testing, and help them sort of sometimes separate the two for themselves and also family members, and give them really our assessment recommendation for screening for the family as a whole.
Thank you. My next case is someone with a BRCA1 mutation. She comes to clinic and she wants to know what her screening is. Beth.
For a BRCA1 patient? Oh, Pamela, you're testing me.
I have a panel member who has a BRCA1 mutation, so I thought rather than talking about RAD51 next, we'll talk about BRCA1.
Okay. Julie, help me out here.
Yeah. So BRCA1, I saw that question in the Q&A, and I'm glad we're talking about it. Interestingly, there is a set of these genes that if you are a molecular genetic nerd, which many of the people on your screen are very similar to each other. So they all work together. PALB2, BRCA1 and 2, RAD51C, RAD51D, BRCA1. What we have found is even though inside of your cells, they all work together, having an inherited mutation in one of these genes plays out really differently from person to person. And we've kind of started to talk about that. But BRCA1 gets lumped together a lot of times with RAD51C and RAD51D. And maybe you've never heard of any of these, but those are three genes that often get lumped together. What we have found, and they're relatives of BRCA1 and 2, they're milder relatives. What we have found is the ovarian cancer risk, as more and more studies were done, was really proven for all three of those genes. The breast cancer risk has really only to this point been proven for RAD51C and RAD51D. So is there still a theoretical reason that we wonder if BRCA1 is a breast cancer gene? We wonder about it, but the studies are not confirming that. And so it is either that it is, and our studies haven't proven it yet, but it could also be what Marta's talking about, is who shows up for genetic testing? People who have lots of cancer in their family. And I think that concern about familial breast cancer is probably the thing that most people are familiar with. So it's also possible that in some of these families that have a BRCA mutation and have cases of breast cancer, that there's something else that's causing the breast cancer that's not the BRCA1. So that, I think, comes back to this idea that we want to look at each person and their family history and all of their risk factors together. Right now, BRCA1 is a proven ovarian cancer risk factor, but not a proven breast cancer risk factor. And then I would tell you, send you to Beth.
And I think this is really what, if I can make a shout out for my amazing team here, is that some mutations are more complicated. Some mutations are very rare. We don't have a lot of information about it. The family history and other cancers, age, circumstances all play a very strong role. So while we have guidelines, what we do for certain mutation for certain people, everyone who comes to the clinic will get a very tailored recommendations of what their screening looks like. And what Beth really is doing amazingly well. She not only with Julie and Martha devises your plan for screening, but she also helps you schedule it and getting it done. And like what Beth has shown in some amazing research, if someone has a screening plan and we schedule this and help people getting this done, 85% of our patients have their scheduled screening done within a month of their planned screening. And I think this is an incredible accomplishment, because I remember when I was in this situation where I got this blueprint of all the things I need to do with myself. Even for me as an oncologist, it was exceedingly difficult. Who does my colonoscopy? Who does my ovarectomy? Who helps me with the pancreatic cancer screening? And I think this is what the clinic does. It helps you at any age to find out what you need to do next and then help you get it done. I know we're at the end of our panel. We're now going to answer questions. There's a lot of questions about what happens to hormone replacement therapy, what happens to birth control. That's addressed in one of the amazing webinars we did before. We talked about ovarian cancer, who's at risk, what surgeries, what and when. We have a whole webinar on the different ways of doing risk-reducing surgeries, what their options are, what the surgical techniques are. This is on our website. Please feel free to look at this. If any of the panelists has any questions, please ask it now before I open it to the forum.
I wanted to comment, as a medical oncologist, I send lots of people to your clinic, and there are those patients that, two things that we haven't brought up are when patients get the report describing a VUS, a variant of unknown significance or uncertain significance, and then also that's, question number one, I try to explain to them about, as we test more and more patients, that this really often represents just a misspelling of a word or a gene, that as we test more and more people, we find out that everyone's genetic code is not spelled the same way. And oftentimes the spelling, doesn't matter. It's like spelling endeavor the British way or the English way. We can still all know that it's endeavor. But in terms of, patients that get a VUS, I'd love to hear about the cancer risk program, the approach to how patients, those things can be resolved, and understanding the value of going back and checking in to find out if someone has a VUS. So that's one question I had. And the second thing was that, you have patients that have these incredibly compelling family histories, and yet you do the genetic testing and they come back, negative for all genes, and yet they are just so sure that there must be some, hereditary predisposition. So there's interest in these polygenic risk scores. So I wondered if, you could say a little bit about, the VUSs in terms of the approach. How do they get justified as being benign, pathologic, that sort of thing? How do they get, and then what about the future of polygenic risk scores? Anyone can answer those questions.
Let's see. I can start, and then Julie can jump in and give her take. So, starting with the VOS, you actually, Dr. Melisco, how you describe is absolutely how we talk to patients. That by doing genetic testing, we read the code, and sometimes it doesn't misspell. It's actually not a misspell, right? It's a different way of spelling that does not affect how a gene works.
Mm-hmm.
And the more we test and the more we sequence, the more we learn about our genes. Genes didn't come with instructions for us, right? And we're learning by doing. So, but the lab continued to add more and more information, and basically how we resolve some of these VOSs is just like finding other people with the same information and studying their family and their presentation. And so this, first of all, when someone comes to us with one of these uncertain, the VOSs, the first thing we do is we review all the information that is available, and then we give our interpretation to the patient. And often we can say, oh, this looks a little bit more suspicious, so maybe we want to keep an eye on this. We may want to follow it a little more closely, and this might be something. But that's actually the vast minority of what we do. Generally speaking, we don't find anything that is particularly concerning. And so we tell our patients, we are treating this like an uncertain, like a negative result. So this is not to be incorporated in your medical care. But the lab does continue gather more information, and with time, they will be able to confirm if this is a benign finding that as we are suspecting. Unfortunately, there's nothing in a lot of cases, there's nothing specific that can tell us this, like the lab is going to tell us more in a month, in 6 months, in 6 years, right? And so that becomes a little bit hard. So we do tell patients, reach out to us periodically every few years to find out if there's something that we've learned more. Labs also try to disseminate updates, but that's not always easy for this to reach back to the patient. The patient might move, they might change provider, they may not be in the system, they may change contact information. So we can't always provide that information. So we encourage patients to basically reach back to us and talk to find out more about this.
And I do some
It's
people.
really important.
Absolutely. Julie,
it's really important for people to check. It's really important for people to check back in. I actually like to answer one of the attendees' question, which is a really good one. It's like, is it possible for cancer to be missed even if you do high risk and intensive screening? Dr. Melisko, you want to take that?
Yeah, so I mean, despite our best efforts, and even when, patients go to extremes and have, opt to have bilateral mastectomies, go through all the risk reduction, and even, perhaps even taking tamoxifen, which we didn't touch upon for a risk reduction strategy. There are patients that still, despite all this, will be diagnosed, with breast cancer, or in some cases, other cancers. And, it's an incredibly, unfortunate thing. We feel that, we feel like, especially for someone, if they did everything the doctor told them to, they came in for their screening, and, we're always, going to miss some patients. And, the only thing that I can say, because I know there's someone in the audience that this happened to, is that it is, difficult. It's hard. It's so tragic. We feel terrible that we didn't, do the best that we absolutely could. I think that one thing that's important in terms of understanding, and I don't want to overspeak, my time and my space, but bilateral mastectomies, do only remove, about 99% of the breast tissue, and it is possible to still develop a breast cancer in the residual breast tissue. So it is sort of like patients still have to be diligent in terms of if they have awareness of a lump, in their reconstructed breast. Of course, sometimes 90% of the time, those lumps are going to be fat necrosis or some scar tissue from their breast surgery. But it's never, you can never, the squeaky wheel gets oiled. You can never be too, in my mind, too diligent and ask for, advice. And if a patient is doing all those things, I think that's the value of being in a high risk clinic and getting physical exams. For a long time, I think during COVID, there was, people weren't going to the doctor. They weren't, getting their body checked. You know, they weren't the laying out of hands and doing a physical exam is so meaningful. So yeah, it's very hard because then, you know, you diagnose someone who did everything and then they now have an invasive cancer, sometimes an incurable cancer. But again, even in those circumstances, that kind of segues to, you know, another question is, you know, what happens when you are diagnosed, you know, and if it's an early stage breast cancer, we kind of talked through that whole scenario. You know, if it's a late stage cancer, whether it's prostate or pancreas or breast or ovarian, you know, there are, you know, obviously more treatments available to someone who has a BRCA mutation or a PALB2 mutation. We're understanding that these PARP inhibitors work across a lot of different cancers in the metastatic setting. And you know, patients can have tremendously prolonged courses of stable disease. I have a patient, you know, with metastatic breast cancer who's on her 5th year of being on a PARP inhibitor with great quality of life. But, you know, those patients that have, you know, whatever cancer it is that they're diagnosed with, you know, they have all the standard treatments. And then I know you have an incredibly active research program in our phase 1, you know, where we have a tremendous number of trials that involve not only PARP inhibitors, but other you know, drugs that impact those pathways that the PARP inhibitors talk to, like Julie was saying. You know, these are all these genes encode for proteins that talk to each other about DNA repair. And I know that's a huge area of research. So, I mean, I'm optimistic. I mean, it's obviously when we don't achieve what we hope by prevention, you know, we hope we can improve with treatment.
Thank you. And that is actually one of our attendees' questions. Some of these mutations increase the risk for other types of cancer, like ovarian or pancreatic cancer. Are there better screening tools in the pipeline for ovarian and pancreatic cancer? I think we have an excellent webinar on the screening for pancreatic cancer. I think the pancreatic cancer screening is going to be very significantly intensified for many mutation carriers, including BRCA2 and ATM with family history, or maybe also without family history. So we're likely going to start doing MRIs or even more for pancreatic cancer screening. The ovarian cancer screening has gone from doing transvaginal ultrasounds and CA-125 to a bit less because we just don't have any good screening. I am very, very hopeful that we have research going on at UCSF to finding biomarkers for early ovarian cancer screening that is blood test based. I think in the next 3 or 5 years, even probably sooner, we're going to see a big change in how we screen. And then really to what Dr. Malisko was alluding to is like finding cancers early is an incredible difference in outcomes. Finding cancer that we missed by someone coming in quickly when they find a lump. And I'm sure you can my chart best anytime when you get a very quick answer back and like, come on in, we evaluate you. And most of all, please don't do video visits with our clinics because we need to examine you. It's like, it is very, very difficult to examine someone over a video. If you have any concerns or anything, please come in person. We'll do an exam. It's like we detect many things that you may not have even been aware of. So next question. I'm 32 and have very dense breast and I'm BRCA1 positive. Can I do MRIs every 6 months instead? Are mammograms helpful at all? Or I'm just exposing my breast tissue to more radiation therapy right now. At 32, this is actually an excellent question. I don't think we have the answer to. We have the recommendation, which would suggest that we do MRIs and mammograms every 6 months, alternating. Whether this is the right thing for you, whether the guidelines really always apply to all the individuals, that's what our clinic is for. So please come in and we make a recommendation for you how do we deal with this. There's one question that Beth has been amazing, of course. I would think this is. There's one. I had genetic testing done over 20 years ago. Is there an advantage to getting retested? Thank you so much for this question. Like Julie or Martha. The answer is yes. So my point is, please tell us why.
Yeah, I think we get this question a lot now because tests have changed a lot. So I do agree with you, of course. What I would say is I don't think the accuracy of testing has changed significantly. So if your test result was positive in the past, I'm not saying go get retested because it's wrong and it's going to be negative. What has changed a lot is what we test for. I actually just saw someone today that I tested 10 years ago, and I tested, and her mom was BRCA1 positive, and I only tested for that exact mutation, which was what we did 10 years ago. But we didn't test her for BRCA2 or other genes, which I offered her today. So I think the reason for coming back, so yes, I do agree that there's reason to come back. I do want to emphasize that it isn't because we think that your result from the past is not accurate. But there may be a lot of other things that we couldn't look at yet, particularly if there's a lot of other cancers in the family. Some people do come back and we look at it and say, oh, like there's the cancer in your family is all explained by what you did before. We certainly could look because we don't want to miss something, but there isn't like a burning question we must answer. Other people come in and we're like, oh, there is a burning question. The person I saw this morning, we're in a different branch of the family than all of the breast cancers. There was another early onset other cancers. And so we will relook at it again, absolutely valid and available to test again. But I just want to emphasize it's not because we think the result is going to change from the past. It's just that we can look at more things. And I know this isn't a genetics talk, but Dr. Mosko asked about polygenic risk score. So I do want to just quickly wrap that into this question, which is, all of you are finding out just how nerdy this panel is. We're talking about all these genes work together inside your cell. And then there's polygenic risk scores. This is essentially that thing I was vaguely alluding to where I said, you know what, there's some families that have other risk factors that don't show up on our current tests. And what Dr. Malisko is referring to with polygenic risk scores is we have talked about genes where you have a genetic mutation in one of these genes and it doubles your risk, it triples your risk. We can use that information on its own. There are a lot of other genetic differences between human beings that just, they really do change your risk, but by a tiny, 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 tiny amount. And if you look at it on its own, it's not helpful at all. What people have done is they've tried to do polygenic risk scores. So they put them all together, like usually about 100 to 200 of these, and they multiply them together. You should look at the research papers. It's just all numbers and squiggly lines and differentials and things. And they try to say, can we put this all together to estimate risk? That is something that is definitely, when Dr. Munster talks about all the screening tests that are in the pipeline, I think polygenic risk score is really interesting. It's developing. There are research studies where you can get a polygenic risk score for breast cancer. The Wisdom study is one of those. We are still really cautious about using these clinically because you can imagine if you take 200 things and you multiply them together using some very fancy math, just the error bars or the kind of range of risk that comes out, we have to be really careful of how we use them. So I think they're interesting. I think they're coming, but we still really encourage using them mostly in a research setting or in a very careful, like informed consent discussion setting, and not something we would use for everybody quite yet. But in general, the retesting, the traditional testing, yeah, that's changed a ton in the last 5-10 years.
Thank you. So I'm going to be 56 and BRCA1. How will my life after surgeries be? Every surgery is different and people have different complications, but I think anyone can probably attest to the fact that I didn't skip a beat. I had both surgeries and had them all in 1 year, and I think Julie, you probably got more of me than less of me right after my surgery. So I think, be prepared that the surgeries are they're not technically difficult, but they're emotionally difficult. And I think it takes some time to heal, and it takes some time to process. And that's where I'm really feeling very, very strongly for people with BRCA mutations who will have a surgery at some point in their lives. Have a good plan on how you take your time. And most of all, what I can say, what helped me the most, other than having friends and family and an amazing support system, being kind to yourself. Be kind to yourself when you go through these surgeries. Don't make any life changes. Don't make any big decisions. Just take your time. Be kind to yourself, and know it'll be better. In the end, it's like, it's not a walk in the park, but your life will go back to normal. So that's, of course, a very personal statement, and I'm not sure there's much the panel can add here. So I'm going to go to the next question. And what is like Dr. Melisko, BRCA2 metastatic disease. What's new on the horizon?
Oh, I was hoping we'd get to that one because I was like, oh, there's too much to type. But so as I mentioned, the, mainstay, of the treatment for a BRCA patient once they develop metastatic disease, and we're focusing on breast cancer, is, to understand the underlying biology. And the reason I say that, and I just came back from attending the School of Breast Oncology, which is a kind of a boot camp for breast cancer, where all of the data for all different tumor types of breast cancer tumor types are presented over a course of 2 days. And I got to hear, some of the big shots in breast cancer, talking about the updates. And we actually had a case of a, BRCA2 mutation carrier, where the decision was, should a patient with newly diagnosed metastatic disease be treated upfront with a CDK4/6 inhibitor plus endocrine therapy, which is what we would give a BRCA2 mutation carrier, or should they get a PARP inhibitor upfront? And the consensus of the panel was, we would treat that patient like any other hormone receptor positive metastatic breast cancer. So if it's someone with ER positive disease, they start with endocrine therapies. But of course, PARP inhibitors play a huge role. So if for those patients with an ER positive breast cancer, they would go through a series of treatments as any patient with ER positive metastatic breast cancer would. And then when we reach a point where we would think it'd be time to transition to chemotherapy, then we would consider a PARP inhibitor based on several studies that have shown that, PARP inhibitors can actually perform better than chemotherapy in this patient population. And then, as I mentioned earlier, and then if you have a triple negative breast cancer, the same thing holds, that the standard of care for a triple negative newly diagnosed metastatic disease, if they have a PD-L1 marker, they would get immunotherapy. If they did have a PD-L1, they would get immunotherapy. If they don't have a PD-L1 the positivity, they wouldn't. And in that case, I think it's tougher because I am inclined in a triple negative patient, depending on their burden of disease, to start with olaparib or a PARP inhibitor right up front, even though most people, if they're PD-L1 positive, would start with immunotherapy. But looking ahead, I think I'm excited about some of these other agents that we're looking at combining with PARP inhibitors. I think looking at combinations of, particularly for the triple negative patients, immunotherapy plus different PARP inhibitors. I think it's amazing how many different PARP inhibitors are in development to try to make them, more effective than the first generation PARP inhibitors that we have, trying to reduce toxicities with them and combining them with other ways to extend the benefit of PARP inhibitors. But I think that, what is exciting about, the breast cancer is that, we're learning more and more about biology and finding more mutations and hopefully finding, targeted therapies. But yet again, BRCA mutation carriers, their tumors are very responsive to chemotherapy. And I think that in this day and age, many cancer patients in general, they hear so much about targeted therapies and they think that they're never going to need chemotherapy or that they shouldn't get chemotherapy. And I can't tell how many patients, have had to face getting a PI3 kinase inhibitor, and then they take capecitabine, a chemotherapy, and they say, well, that capecitabine was so much easier than my, alpelisib or my, capivasertib. So while we're excited about all these targeted therapies, it's again a conversation about, what are the toxicities people want to avoid. But thankfully, PARP inhibitors, are, often do provide prolonged, durable response for patients with BRCA mutations in the metastatic setting. I'm curious to know, in your experience, since you treated so many, what is the longest duration of time you've had someone on a PARP inhibitor? Because I said I have someone who's, over 5 years at this point and doing great.
Probably approaching 7.
Yeah. Yeah. So, I mean, it's really wonderful when you get those, people that have those prolonged responses.
And then, nowadays there's an amazing amount of work of like doing antibody drug conjugate, like making the chemotherapy targeted to the tumor and not going anywhere else. We have PARP inhibitor, CHEK1 inhibitors, POLQ inhibitors, POLθ inhibitors, like PARP1 selective inhibitors. It's like, I think I have probably about 10 clinical trials for people with hereditary cancer mutations and metastatic cancers in the phase 1 trial group. So think of phase 1 trials because as access to new drugs rather than being a study participant. This is really where you get access to new drugs. Before we start, I like to answer the last question because that actually comes up a fair bit. I'm 36, wanting to get pregnant in the next couple of years. And I'd really like to breastfeed. Is it a risk at my age to do this? How should I do preventive surgery? Should I do preventive surgery beforehand? My aunt got breast cancer at 38. I think this is a hard one. Please come to clinic and discuss this because it's really hard. I think it depends on what your MRIs beforehand looks like. Are there any changes in there? And as Beth feels very, very strongly about is like, if you want to get pregnant, make sure your imaging is up to date. Just make sure that just before you get pregnant that you do get your imaging because we can't really do good MRIs and mammograms during pregnancy. It's really reduced in sensitivity during breastfeeding. And so I think this is something that's a good plan. We have many patients who get pregnant with the BRCA mutation in our clinics. Mostly what we do is we see patients probably closer to every 3 months for a breast exam when they're pregnant and closer before delivery. So we follow people very closely. And it's not a direct no, but I think that should have a plan. Bess, would you like to add anything?
Well, I think I was telling you the other day, I joke with people and say, I know I'm not the person you're thinking about when you're about to get pregnant, but could you please contact me anyway so that we can make sure that if it's been more than 3 months since your last imaging, we can get you re-imaged before you get pregnant. Yeah, and it is hard for women to do self-exams when they're pregnant because their breasts are changing week to week, and so they feel really different. We will, for people who have really bad or strong family histories, I should say, we are happy to do more frequent exams. I also encourage people, if they don't want to come see us, to have their OBs do it or their midwives. I mean, they're between those visits, between us and their OBGYN care, they can get pretty frequent exams. And if they feel anything is out of the ordinary, don't hesitate to contact us. We will have you come in. We can do ultrasounds. We can do mammograms at a certain point in the pregnancy. We just don't do MRIs.
With this, thank you so very much for attending. Thank you, the panelists, for this highly informative session. And I think with this, I like to adjourn. Thank you, everybody.
Thank you. Good night.